Hello, good evening. I am Apala Agrawal and I welcome you to Library's YouTube channel for another live session. Today we have the privilege to host Dr. Padmaja Loki Reddy, hematologist and BMT consultant at Apollo Cancer Institute, Hyderabad, India, and MBBS and MD. She has also done MRCP from Royal College of Physicians, London, and FRC Path Hematology from Royal College of Pathologists, UK. She has earned a number of awards, but to mention few, her achievements include Brand Icon Award 2020 for Healthcare Excellence in Hemato-Oncology and Bone Marrow Transplant for year 2019 to 20 by Time Cyber Media. Dr. Padmaja has a meritorious award in the field of hematology and transplant by International Biographical Center, Cambridge 2016. She has also been included in International Biographic Dictionary, Cambridge, and recognized in Top 100 Physicians for 2016. Currently, she is practicing hematologist and BMC consultant at Apollo Cancer Institute, Hyderabad, India. Previously, she has worked as hematology and transplant consultant at different prestigious university hospitals at Glasgow, Birmingham. She regularly updates herself and keep up with recent advances in her field like CAR T cell therapy. Being visiting consultant at Johns Hopkins Institute, USA. Her recent work includes transplant and CAR T consultant at Manchester Royal Infirmary and actively trying to bring this treatment to India by forming international collaborations. To her credit, she is the first doctor in India to have clinical work experience on CAR T cell therapy. With all of her experience and expertise, it is a privilege to invite her on a platform and educate our users on is BMT a surgical procedure or a medical process? End of the session, she will also take up all your queries. Welcome, Dr. Padmaja Loki Reddy, and thank you for taking out your time. Over to you,
Thank,
Doctor.
thank you, Apila, and thanks for Library for giving me this opportunity to connect with common people and look at their questions. And we will discuss about some of the common myths people have. And overview would be about talking what is the difference between different types of transplants, like organ transplants, many people would have heard, and what is it different from bone marrow transplant? Is bone marrow transplant and stem cell therapy are one and the same? And what are the new advances? What is the procedure of bone marrow transplant? Is it medical, surgical? How does the process go along? And what are the indications? So we will look at all these things in detail. For the ease of the viewers, I made a small PPT so people can, if they've not caught up, they could read. Let me screen share. So I hope it's visible nicely.
Yes, ma'am.
Thank you. So different types of transplants. We have a solid organ transplant, like all of you would have heard about kidney transplants, liver transplant, pancreatic transplants, which is another newer phenomenon, mainly for diabetes, and heart and lung transplants, corneal and skin transplant. Many of these transplants are all solid transplants. So you've got an organ which is faulty, you're replacing it. And bone marrow transplant is slightly different. It is a liquid type of transplant. It is not a solid organ. So look at a few of the differences. Bone marrow transplant, always the transplant donor has to be a live donor. Suppose in organ transplant like kidney and liver, you could have a cadaveric transplants like kidney or heart transplant, lung transplants. When somebody have gone into coma or they've had a road traffic accident, people opt for a post death, they would opt for donating their organs. But in bone marrow transplant, they're all live transplants. So you can only collect it from people who are alive, not from the cadavers. And there is no loss of organ to the donor. When you collect the stem cells from the bone marrow, the donor do not lose anything. And the donor doesn't have to be a related one, or they could be unrelated, but they have to be a match. And donor will not have any surgery. A lot of people would worry about whenever there is siblings or a match, they would worry about whether there's going to be any harm for their future. So if there was any harm, we would not collect stem cells, or donors will not be asked to give stem cells voluntarily for unrelated whom they are not connected to. So that makes you think that this is such a safe procedure. Worldwide, people are donating their stem cells. They would not lose much. So what we donate as a donor is a drop in the ocean, and you will get it back. Something similar to blood donations or platelet donations, you will get it back. So that kind of a fear should not be there. It is much easier now. And a lot of people have this thing, is the donation a surgical procedure? Leave alone the bone marrow transplant for the patient, the donor who is donating, people think that they would go into the theater and they would go through a surgical procedure where you collect liters of bone marrow. In the bone marrow stem cell collection, there are two different processes. One, we can collect it directly from the bone marrow in the surgical room, which we rarely do it these days. And majority of the times, more than 90% of the time, especially unrelated donors, we collect from the blood. So we give some stimulating agents where the stem cells are produced in excess, and the donor is connected to the machine, and we collect the stem cells. So the donor will lose an organ in solid tumors, but in bone marrow transplant, there is no loss. That is something very important, and it is very safe to donate. Of course, there are a lot of medical checks one would do to see whether the donor is safe to donate. Donor safety is a priority before the patient. And what is a bone marrow transplant? When we are going through a stem cell transplant, there are different things we need to look at. Before we go through that, I just want to add one more point. How do we decide who is the donor? We do a special blood test called a HLA typing. This is similar to white cell typing. So you know the DNA signature is quite specific for each person. When you are genetically a siblings, like your brothers and sisters, you get half of your genes from your chromosomes from your mother, half from your father. So if you're sharing the similar half set, you could be 100% match. So among the 4 siblings, one could be 100% match. So for bone marrow transplant, you need a white cell or a HLA type match. In a lot of other organ transplants, you have to be a blood group match. In bone marrow transplant, you don't have to be a similar blood group. You can donate with a different blood group, but you have to have some degree of a HLA matching, that is a white cell matching. 10 out of 10, that is 100%, is the best one. But people can go for a 50% donor, but that had to be a related donor, that is a father or children or brother and sister who are 50% match could still donate. And when we say unrelated, we do this like a blood group. We do the white cell testing, and you put all these information from the donors on the database. Whenever we have a patient who needs a donor, we do the database search, and we'll find out whether there is a approximate match. And then we do the retesting of the blood. This is just a blood testing. You will get to know whether they are a suitable donor or not. How do we do a bone marrow transplant, and what do we need? First, we need to have a good bone marrow transplant unit where you have a standards to perform this procedure. And then we select out the donor where the donor is. And there is a process what the patient has to go through. It is a non-surgical process. It is a medical process where you would have a week of chemotherapy plus or minus radiation. Stem cells are given like a blood transfusion. And then you are waiting for your bone marrow to recover from it. And we talk a bit about complications and future directions. What are the standards of bone marrow transplant unit? Not everywhere you could do this. These patients are going to become sick after you start the treatment. So we need to have a good air filtration, that is HEPA filtration, and air quality has to be checked with the number of particles. And we need to have a good class of environment, a good positive pressure, so the infections or air movement will go from the room to outside, and the outside air will not enter the room directly. It has to go through the filters, laminar airflow, and we always get a microbiological clearance, not just in the room, also the tap water, the showers, everything have to be screened so the patient doesn't get infection during the time of transplant. And the next thing is collecting the stem cells. Once you have identified the donor, you need to have facilities to collect, that is apheresis room, and you need to have facilities for storing these stem cells. And the special things like a donor lymphocyte infusion when there is a relapse settings, these are the special treatments one should have those facilities when you are a high-end center where you have a number of transplants going on. What are the indications? Why do we do a bone marrow transplant? Before we go, is bone marrow transplant and stem cell transplant about the same? Yes, they both are the same, that especially hematopoietic stem cell transplant. Previously, in the olden days, we used to collect from the bone marrow all the time. That's how the name was given as a bone marrow transplant. But later on, for the last 20, 25 years, we've evolved and we've been collecting it from the blood. So we call them as a hematopoietic stem cell transplant. And what are the indications? Most of the time, we do it for a cancerous patients like leukemias, lymphomas, myeloma, or sometimes we do it for a marrow failure where they don't have a enough red cells or enough platelets, that is aplastic anemias, thalassemias, or there is a faulty red cells like sickle cell anemia. There are various other list of conditions, even including the solid tumors. We do the bone marrow transplant. There are some conditions we do a bone marrow transplant. This is something relatively new, is an autoimmune conditions like systemic sclerosis. And now the auto transplant is also approved for systemic sclerosis and also multiple sclerosis. Few patients with a multiple sclerosis failed 2 lines of therapy could be eligible for autologous stem cell transplant. What are the different types of transplant? There is auto transplant, allo transplant. Auto means you would collect your own stem cells, give a big doses of chemotherapy, and give your stem cells back. This is literally like revamping your bone marrow cells and getting a deeper remission and giving a new, revamping your immune system. Allogenic stem cell transplant is you're giving somebody else's cells, somebody else's immune system, that is your donor's immune system. In a cancer patient, they've developed cancer because lack of the immune system fighting the cancer cells. So you're wiping out the cancer and giving a new immune system from the matched donor. That is the whole point in giving different persons in a cancer patient. And areas where we do other transplants like unrelated, where you can do from the data registry. In India, we have Datri. In Europe, we have a German registry called DKMS. These are the common ones where we collect stem cells. And if you don't have a donor, even on a worldwide search, you can go for a half-match transplant, which is being routinely done these days. And number of complications have reduced as we have learned over the period of time about how to tweak the regimes and follow up. Umbilical cord transplant these days are rarely done. The way it is going down. There are a number of how we select the donor, not just by the HLA match. The younger donor is better. Male sex is always better. And females, if you've taken, you have to take somebody who has not gone through a childbearing type. And CMV status and blood group match is always better. And we want to have a good number of stem cells. This is a picture of one of my patients' donor who is donating stem cells. So you can see there is a machine that is called an apheresis machine, where you can see this is a stem cells being collected. We're collecting blood from one side. It is going through the machine. The machine filters out some of the stem cells, and then the remaining blood will go back through the other arm. And the patient is comfortable, and he is donating the stem cells. So he would have had 5 days of injection at home. And then we know in the blood how many stem cells are there. So when we give this injection, the stem cells will come out from the bone marrow into the blood, and we harvest them on these machines. This is our apheresis unit. What are the transplant process? Once we've collected these stem cells, we admit the patient and we give them conditioning chemotherapy. That is like 6 days of chemo plus radiotherapy, plus or minus. Not in everybody we would give radiotherapy. And once we have done that, the blood counts are going to go down. And we also give immunosuppressants to dampen the patient's immune system, so they would receive donor cells and they would accept the donor cells. If you don't do that, the donor cells will be rejected. And the stem cell infusion, whatever the blood bag, stem cell bag we've collected, we would infuse it like a blood transfusion. That is called a stem cell transplant. After that, the blood counts are going to go down. Patients would go through a neutropenic phase. That means the low counts, where they have infections, risk of infections, need for blood and platelet transfusions. This period is quite critical to look after them, to prevent infections, to prevent any acute rejections. After that, once the cells are coming up, the white cells come up first. We say the patient has taken the graft. That's called engrafted. And after the engraftment, we look out for any viral reactivations, any rejection process. We call it as a GVHD, graft versus host disease. This is the post BMT phase, where we're looking out for various types of reactions like infections and GVHD, how the blood counts are improving, whether we could discharge them and keep seeing them quite frequently. And during the time of transplant, patient is mobile, active, and after the transplant, patient is still mobile, active. And they're eating normal. There is a specific diet restrictions we would give. They're following that. They may lose hair. Most of them do lose hair, and they would all get it back after 3 months. For a layman, it may just look like how they've had their chemotherapy, period of hospital stay, and recovering, but there are lots of a complex process going on. So it appears like giving chemo recovery, but there is a play with the immune system. We're giving a new immune system, which could be quite damaging. There is a life-threatening complication. So one has to be very vigilant, very competent to recognize these complications very early, so you can have a safe post-transplant period. Not just recovering from the transplant, we want to make sure the disease doesn't come back. That all depends on how intensive treatments are, how much you are giving the immune system to fight. So these are all the fine balanced mechanisms to prevent risks and to get the best of the benefits. And it is quite individualized at times, depending on that particular patient, how much they can tolerate. There are quite a few complications we talk about, and we need to look at it. And our aim is for the patient to come off all the immunosuppression after 3 months, at the maximum up to 6 months. In contrast to a lot of organ transplants like kidney transplant, liver transplant, patients have to continue their immunosuppression, that is suppressing their immunity for a lifelong period to prevent the graft rejection. But in bone marrow transplant, things are very strict, very complex. Patients are acutely ill, but once they crossed about 6 months, they're almost back to normal. They're coming off immunosuppression, except a small percentage of patients who go through complications. Majority of them, after a year, they've gone back to work. And once they've crossed 5 years, if there's no disease relapse, they're almost having a normal life. And we look at them on a yearly basis, at a later point after 5 years, to look at a long-term complications if there was any. So I'm going to stop here and open up for discussion to take all your questions. Thank you.
Thank you, doctor, for providing us with such insights over this particular problem. Now we will take some questions from our viewers. So the first is that after bone marrow transplant, how long can a person survive?
So bone marrow transplant is a potential cure. We are doing this transplant with a view to cure the disease. It depends on what transplant you're doing. If we are doing an autologous transplant for a multiple myeloma, it is not a curative option at all. Because we know the multiple myeloma, one particular type of a blood cancer called multiple myeloma, is not curable. And autologous transplant will give them extra time to have any other progression of the disease. So you're giving a disease-free time longer. But for allogenic stem cell transplant, like acute leukemias, when you do it, you want to cure the disease and prevent it coming back. If the disease doesn't come back after a year, 2 years, the chances of it is coming back is less. But if they cross about 5 years, we can say that they're going to have, somebody who don't have a cancer, they could go back to their work and have a normal life, provided that small group who don't have, who have complications. So our aim is to cure the disease and to have a long-term, lifespan. It's only for the first few months and a year there are problems.
Ma'am, do we have any age requirement also for this transplant?
So generally over 65, we tend to be cautious because whether they could go through these complications or not, but it is quite individualized. We're now stretching up to 70 years for patients to go through transplant. If you take a lot of Western countries, now the 65 has gone on to 70. And 70 plus, they're thinking about an individualized whether to go or not. But 65 is a usual baseline. 65 to 70 is on discretion. And it all depends whether they've got a good heart, good organs, whether they can tolerate the toxicity. Even in a younger group, you can do transplant. A lot of young patients tend to have an intensive transplant, what we call as a myeloablative transplant. So younger patients tolerate much better. So we give them more stronger therapy. For older patients, we tweak the chemotherapy to reduce the intensity, what we call as a RIC transplant, that is reduced intensity conditioning transplant. And there are some more concept called a mini allotransplant. That is again to give a lesser amount of chemotherapy for patients to recover quickly and to have less side effects. So the treatments are slightly different, what you give as a conditioning for the age group, but about 65 to 70 is the cutoff. There is no lower cutoff. People can have transplant at any age group if they had a need for it.
Okay, ma'am. And ma'am, what are those rare side effects which a patient can face after this process?
So one, we talked about infections which are commoner, and there is second thing called a CMV, which is one type of virus. People can get these infections, but they tend to settle back after 3 months once we stop the immunosuppression. And one of the most complex side effect is GVHD, that is graft versus host disease. It is like you're giving somebody else's blood. If you give a wrong blood, your body will not accept it. It will reject it and react to it. It is something similar. We are giving a different person's immune system. There is always the fight between the donor and the patient inside at a cellular level. This is what we call as a GVHD, graft versus host disease. This can happen on the skin or liver or gut because they all have an increased number of receptors. That's why you see in these areas. People can have skin rashes, a bit of diarrhea, abnormal liver functions. So the GVHD is one of the difficult one, but there are lots of treatments available. Now it is manageable.
Okay, ma'am. So, ma'am, it's like we talked earlier about the donors. Ma'am, can a father become a donor if his blood group doesn't match with his child?
Absolutely. Suppose, as we said, the blood group is not the first criteria to get a donor. It's a HLA typing. So first, whenever the patient who needs a transplant, we say how many brothers and sisters you have. Let's do the blood test for all of them to look for the white cell typing, that is HLA typing. If we find a donor, that's good. But sometimes we don't find a donor. Then we say, okay, let's put this in the registry and see in the database whether we have anybody in India who would match with this person. And sometimes we don't find any. And then we extend this search to European search or international search. And sometimes we don't find a full match in the whole of the world. It is surprising how we do. And sometimes for an Indian patient, you don't find a match in India, but you could find in Germany or Poland. It is just the way we would find the HLA typings. If you don't have a full type, or you can't wait for this Western donor to donate, we don't have time, then we go on for a half match. That is, parents will definitely be a half match. There is no doubt about it. Genetic mother or father will definitely be a 50% match, or children will also be a 50% match. Again, mother and father, whom would you choose? Father is better compared to the mother. So the male transplants are better. Male to male is better than female to male. So father can become a donor if we don't have an option of the other two. Yeah.
Okay, ma'am. And ma'am, is there any kind of diet which a patient should follow in this process?
So during the transplant, we call them as a neutropenic diet. As we said, the 6 days, there is an intensive treatment with chemotherapy plus or minus radiation and also immunosuppressive therapy. At that time, the blood counts are going to go down. So we need to protect the patient with a good diet to prevent any infections. So we tend to tell them completely a full cooked diet, and there is no salads. So we're not eating anything uncooked. There is no raw salads, all this. The skin has to be peeled off completely from any of those fruits. And we tend to prefer the fruit which has got a tight skin. So there is no risk of infection, like bananas or oranges, which has a tight skin. Or people can peel some of once the neutropenia recovers, we would allow them to have apples, but it has to be completely washed and peeled. And sometimes when they're acutely ill, we would ask them if they want to have cooked apples and things. Many people don't like it, but they could have juices at that time and have good protein diet. There is no problem with eating non-vegetarian diet, but it has to be fully cooked. And the food has to be freshly prepared, should not be left out for a longer time and put it in the refrigerator and reheating. That's all to be prevented. They could still have yogurt, milk and milk products. There is no problem with it. The bottom line is nothing raw. It has to be fully cooked and there is no storage. It fresh and it should be consumed. And we tend to tell them patients should not use alternative medications. wheatgrass, aloe vera, papaya leaves, and people use a lot of raw things. We should avoid that, because you can imagine any tree which is sitting outside, there's a lot of dust. So there's a lot of fungal risk. When you consume such things, there is a risk of a fungal infections. Even a post-transplant period, one important thing patients or relatives of transplant patient need to know is you should not give anything without informing the doctor, especially the homemade cocktails, with the different leaves. People make kashaya, that should not be consumed because they are uncooked. They could be harboring a fungus, which is usually there on the tree barks. So people should avoid that. I want to give you an example. There is a patient who had a fungal infection in the gut, which is very, very rare thing. This could only happen by consuming tree barks, or they were making some kind of a homemade kashaya. So it's important not to take any over the counter or alternatives without informing your doctor during your acute phase of your treatments. Sure.
Okay, ma'am. And ma'am, when is the stem cell transplant recommended?
So there are different indications where you would do a bone marrow transplant or a hematopoietic stem cell transplant. Common indications are cancerous conditions, like we do your own stem cell transplant called auto transplant in conditions like multiple myeloma, lymphoma, and allogenic stem cell transplant, that is different persons' stem cells and immune system, is in acute leukemias or bone marrow failure syndromes like aplastic anemia, where you have an excellent results if you've got a good donor and the transplants are done at the right point of time. Patients coming at a very later date, people can have a bad outcome. So good point in time to have a transplant is important. And Fanconi's anemia in children, leukemias in children, and immunological conditions like systemic sclerosis and multiple sclerosis, or some of the vasculitic conditions where you would do auto transplant to reboot their immune system. So those are the thalassemia is another common indication in India where there is a defective red cell production. And these children would need a regular blood transfusions. In order to get them out of this, we would do a bone marrow transplant. In thalassemia, in most of the children, it's better to do the transplant before they've turned into 10 years to have better outcomes.
Okay, ma'am. And ma'am, is this bone marrow transplant procedure same for children and adults, or is it different?
That's a great question, Apla. I think one of the viewers have been asking this question. For children, we do much stronger transplants if it is a cancerous condition. If it is a non-cancerous condition, we would do a less intensive transplant. So the treatment what we give for the 6 days before giving the stem cells is what we call as a conditioning chemotherapy. We give a total body radiation, whole body radiotherapy along with chemo in cancer patients, especially children below 15 years age group. Adult patients, we never tend to give a whole body radiation at higher doses. In a half match transplant, we give a very small dose of total body radiation in order for the graft to be taken. So the regimes are a little different between adults and children, and also depending on the type of transplant, we would vary accordingly.
Okay, ma'am. And ma'am, how long does it take for recovery from BMT?
So the whole transplant, if somebody is going through transplant, we tell them you would have 6 days, 6 to 7 days of treatment as an inpatient, that is called conditioning chemotherapy. After that, we would have their stem cells given to them. And then they're waiting for another 2 weeks for the blood counts to recover, where we call this as graft is taken, that is engraftment. Once the graft is up, we discharge them. So that is a whole period is about 3 to 4 weeks they're in the hospital. In that period, about 10 days is quite an acute and critical period. Once they're discharged, they would be seen quite frequently as an outpatient. So overall, for your question, they are in the hospital for 3 to 4 weeks, but as an outpatient, we'll be seeing them quite frequently until day 100. So that is 3 months after the transplant. They're almost coming once in 3 weeks, 4 weeks for a blood test and a review. And once they've crossed that period, they've stopped their medications, that is immunosuppressive medications, no complications, will move their regular visits, outpatient visits. Yeah.
And what all tests should be performed prior BMT?
So we talked about for the donor, we do a lot of tests depending upon their age. The basic tests are like CBC, liver, kidney test, ECG, to see that their kidneys are okay, their lungs are fine, their heart is good. So those are the basic things, and their blood group, and whether they're safe to donate, and their history, medical history, examination, viral testing, all that. For the donor, other than all these organ testing, we would also do a lung function test called PFT. We would do an echocardiogram and also look at what they have had, the history. In the past, have they gone through a major problems, and try and look for anticipatory problems. So if I take this patient go through transplant, what would I expect? What could happen? We have to identify, think about it, and think about the measures, how to prevent it. And they would have lung function tests, echocardiogram, ECGs, and disease reassessment like PET CTs, bone marrows, to see how much disease is there before the transplant. Ideally, we want to get the disease under control to a very, very low level before the transplant to have a better outcome.
And ma'am, is it also possible that this BMT can cure blood cancer?
Absolutely. That is one of the ultimate aims of bone marrow transplant. Majority of patients go through allogenic, that is different donor allogenic stem cell transplant for leukemias, that is acute leukemias, AML. Without a transplant, AML outcomes are about 10 to 20% in a high risk patients, about 30 to 40% in the in between patients. So with a transplant, we are moving, shifting the curves. Quite up to 50 to 60% of patients we are rescuing. So transplant is very much on the card, and it saves the patient, it cures the disease, especially if the transplant is done at the right time. The timing of transplant is very important. Many of times in India, we have a myth thinking that my disease is under control now, I won't go for a transplant. God is on my side, I'm not going to get a relapse. Somebody might get it, I won't get it. I think it's a human nature for us to think that nothing will happen to me. But when you have a relapse disease, the transplant outcome is not good. So the first time when you have a bad disease, you should get the treatment, get it under control, and have a transplant. Your outcomes are good at 70 to 80% in leukemias if you had a right way of transplant. But if you had a disease relapse and then have more chemotherapy and then having a transplant, your outcomes are hardly about 40 to 50%. But if you didn't have a transplant at that time, whatever the treatment you give, it is only going to hold it for a period of time. And long term, more than 5 years, survival outcomes are less than 10%. So it is very important to have a transplant at the right point in time. That is especially in a high risk patients, to have it soon after the chemotherapy rather than waiting for it to come back and then have a transplant. Many people think like that, when it comes, I will do it. But that's not the right attitude, because the outcome is not good at that time.
Okay, ma'am. And ma'am, can a patient undergo a BMT more than once?
It's a great question, Apla, you've asked me. There are times we do more than once. Suppose if we take a multiple myeloma patient, that multiple myeloma is a type of blood cancer. It involves bone marrow, kidney, and bones, where we do autologous transplant, that is their own stem cells we give. So in order to give a big dose of chemo, we give their own stem cells to rescue. So in those patients, you can do 2 times auto transplants back to back. Like it has to be at least about 2 years gap before they relapse. Then you can do another auto transplant and give them a longer time. But allogenic stem cell transplant, that is a different donor transplant, it is generally not recommended to do a second transplant, but there is a lot of evidence, especially in children. They can tolerate even a second transplant as long as the relapse has happened more than 2-3 years. They tend to respond again. But if they've had a transplant, they've relapsed within 3 months, no way they're going to respond to another transplant from a different donor. So it's important to see for the second transplant, especially in children, you need to have a bit of a gap, and if the disease comes. But we don't have to go for a second transplant now, because there are a lot of new treatments available like CAR T cell therapy, which is changing the outcome of patients who relapse after the transplant. There are a lot of new cutting edge therapies are evolving. Of course, they're very expensive at this stage, but I'm very positive that it will come to India shortly.
And earlier just we talked about that CAR T cell therapy. So actually, what is this CAR T cell therapy?
So before I say about CAR T, I want to say what are T cells? In the blood, we have three different types of cells, like red cells, white cells, and platelets. A lot of us would have read in biology all this. Red cells carry oxygen, white cells fight for infection, platelets prevent bleeding and bruising. In the white cells, there are different number of different types of white cells, like neutrophils, lymphocytes, eosinophils, all these three different things we would have heard about. So neutrophils fight bacteria infection. The lymphocytes, there are B and T type of cells, which will have a different function. Like T cells are the one which kill the virus. And during the COVID time, we all heard about this T cells. So the viral infections are prevented by T cells, but cancer cells are also killed by T cells. So when some patient has got a cancer, that means all of us would have some disruption, and there is a small generation of a cancerous cell, but these T cells will control them at a microscopic level. But why patient develops cancer is these T cells are not able to recognize them as a cancer cells, and they're growing. Though there is a policeman, the number of awkward cells are growing in the blood. So this is a T cell which fights the cancer cell or a virus. So what we are trying to do in a CAR T cell therapy is, this is called a CAR is chimeric antigen receptor T cell therapy. So what we want to do is, on the cancer cell, there are some receptors. We want to find what receptor is there and take the patient T cell, collect some T cells from the patient, which you can do something similar how I showed the picture. How we collect the stem cells, we can collect the T cells as well. And then we take them to the laboratory, we potentiate their function, we give them some markers. So you're giving them, this is how the cancer cell is going to look like. So this is how you have to fight. So you are actually programming them, genetically you're programming them outside the body in the laboratory, growing them and then giving it back to them. Like how we have given the stem cells, we give a bit of chemotherapy and give these stem cells, CAR T cells back. So it is such a personalized cancer treatment. You're removing a person's T cells. In the laboratory, you're making them very potentiating by genetic methods. You're modifying them and giving it back to them to fight their own cancer cells. So this is what is a CAR T cell therapy. And the CAR T can be against a specific, antigen like CD20 CAR. CD19 CAR is the normal one in acute leukemias or a lymphomas where we have, relapse refractory lymphomas. You have a CAR T cell therapy. So this is their own T cells. You are potentiating them and giving it back to fight against their own cancer cells. I hope I made sense. It's a bit complex.
Ma'am, yeah, a little bit. So, ma'am, that's why I was just want to know that does this work for patients who relapse post chemotherapy or who don't respond to chemotherapy?
So that's a great question, Apla. If somebody who had cancer, they've taken chemotherapy, they relapse, they have one more chemotherapy, sometimes they go through transplant. Even after the transplant, they still have a lot of cancer cells, or it's come back after the transplant, then those are the patients who would benefit from CAR T. Or there is a lymphoma patients, they've had a cancer, they had one line of therapy, they had some time, it's come back, they had another second line of therapy, again it's come back. If you have a lot of disease which are not responding to chemotherapy, that is chemorefractory disease, transplant will not hold them, because transplant is nothing but a lot of chemotherapy and immune system. So those are the patients who don't respond to standard chemotherapy are the ones who would benefit from these T cell therapy, because you're targeting them in a different way. It's not the same way. And they're very much potentiated T cells.
So, ma'am, can we say that this is the future personalized treatment?
Yes, I think the time will come, we will start, because it's very much personalized. As you've seen that we are collecting these cells from the patient, making them more potent, engineering them genetically in the laboratory and giving it back to them. The time will come, we will start to make CARs for all the cancers. But currently we've got only few cancers where these treatments are available. There are lots of side effects in the beginning. Like we went through a first generation CAR cells, and then we tweaked how the response is. Toxicity will be less. There is a second generation. Now there is a third generation CAR cells, which are available with a less number of side effects. So I think the future is going to be, it's not going to replace a transplant, but they've got their own value. in patients who don't respond to chemotherapy or who relapse after the transplant, or they could be elderly patients who can't go for a transplant. Those are the patients could be able to tolerate the CAR T cell therapy. So there is a role. I'm sure this is going to change and evolve and improve the patient survival, not just the survival, to have a good quality of life as well.
Thank you so much, Doctor, for such a wonderful insight. I hope our viewers will understand this completely. And to all my viewers, we hope that we could cover all your concerns related to today's topic. Library is always here to convey true and authentic information related to all health-related queries to its user. For further updates, stay connected with Library, and thank you.
Thank you,
Thank you
Apla.
so much.
Thank you.